deliver the best clinical care to patients. So we do that by our curriculum that we've developed, as well as hosting presentations and inviting researchers and clinicians to come and share their latest work with our community. We are a membership-based organization. So we have members in over 30 countries. We have 4 different membership types. So if you're interested in joining, but you're not a clinician, that's totally okay. We have different categories, and we really are welcome and open to everyone coming in and joining, learning more about cannabis education. We have a private online membership community. So we'd love to have you in there to contribute any articles that you've been working on, or ask questions, share announcements and events, and just be in community with the other clinicians that we have around the world. I know it can be isolating depending on where you're working, and if you're an academic institution or a clinical organization. It's still, even though there's getting momentum, a lot of clinicians and members that I hear from have a hard time discussing this latest research with their colleagues down the hall who aren't up to date. So we'd love for you to come join us. As a member, in addition to gaining access to our online private community, you get a 20% discount on all of our education courses that we offer. You get free entry to all of our events, including our monthly journal clubs, quarterly meeting presentations, and our special presentations that we have throughout the year as well. We also have a practitioner map online. So any physician or clinician member who is interested in posting their clinical office on our map so that patients can find you are open to doing that. Of course, if you are not ready to be out there in the world, that is an optional benefit. We also have newsletters you get access to, and the opportunity to submit case reports that we'll be bringing back soon. So we're looking forward to diving in today with Dr. Mike Ruggiero. This second course listed here, the Cannabis Pharmacist, a bottom-up clinical approach. These are the 4 courses listed in the curriculum, and there are 4 CPE credits available if you purchase the full package. So you can find all this information on our website at cannabisclinicians.org when you go to the courses tab. In addition to the new pharmacy course that we just launched, we do have an additional clinical training curriculum that is 23 courses, which covers about 23 hours of content. So all of this content was created to be compatible with the cannabis pharmacy curriculum. This course covers the botany, ecology, ethnobotany, pharmacochemistry, also the neurodegenerative and movement disorders, epilepsy, geriatrics, specifics on dosing. It covers a really wide array. So if you've done the 4-course package, but you're interested in diving a little bit deeper, you can definitely check this out and see if you're interested in some of the packages we offer, or you can always purchase an individual course. So I will stop my presentation there and pass it over to you all.
Thank you, Christine, once again for the wonderful introduction, and welcome everybody to another edition of Canna Talk with special emphasis on pharmacy in the cannabis world. So once again, my name is Bobby Vincent here with the wonderful team, bringing you some new information. So today the module we'll be discussing is the cannabis pharmacist and a bottom-up clinical approach to pharmacists in the cannabis industry. Just a quick introduction to the actual module itself. The roles and requirements of a clinical pharmacist in medical cannabis programs vary due to a patchwork of state regulations. Factors include conflicts with federal governing bodies and policies, and the patient experience changing with every dispensary visit. Standardizing practices to ensure patients receive superb clinical guidance while maximizing harm reduction should remain at the forefront of priority for all practicing clinicians in this space. Taking a ground-up clinical approach and working alongside patients requires them to be empowered to make self-motivated decisions. So after we dive a little bit deeper into what this actual module will cover, in you all's own words, guys, tell me a little bit about what makes this module so unique and special for you all. What inspired you to get this active information pulled, and what information did you pull from the pharmacy community?
I guess the thing is that I've always heard pharmacy as a degree be compared to like a Swiss Army knife. Like we have all these like little tools that can be applied everywhere, but it's kind of like how do we apply it? And the tricky part here is, on top of that, the world of cannabis or plant-based medicine in general is kind of very unique to many of us. Like a lot of us don't really know how to navigate it. Like most, at least I didn't have any formalized training in school on this topic. So the goal here was kind of like, how do we, well, one, illustrate some of the differences between the two industries, like traditional based practice versus plant-based medicine practice or cannabis practice, and just broadly give you kind of like a roadmap on how to navigate various programs. Like you said, there's like a patchwork of different laws throughout the states. How do we navigate that? Well, we're not gonna have the time to cover that, but at the very least, we're gonna give you a general, I guess, skill set to kind of navigate it all. But in reality, you have that skill set. How do you apply it to this industry is really kind of what we're trying to get at here.
Yeah, and to piggyback on that, when I entered the cannabis space in 2018, and I just looked around to other people, there was no resources, there were no books, there were no guidelines, protocols, and whatnot. And the best information I found wasn't just from reading, but talking to other pharmacists that are dealing with patients one-on-one. We learn a lot of things through didactic teaching in school. So we go through 6 years of courses, electives, as well as clinical rotations, but nothing really prepares you for the type of patient care that is still needed in this space. We are great at diagnosing and assessing when the physician is, kind of at the head of the conversation. But to do that one-on-one with the patient, that's what the bottom-up approach is. We're literally talking to our patients, figuring out what's wrong, and giving the best advice and knowledge that we can based on the tools that we have. So yes, using the Swiss Army knife of all the things that we've learned, but really building confidence for practitioners as well as mainly specifically pharmacists to be able to utilize those tools to help their patients in front of them.
I was gonna say, Michael, that was my first time hearing the Swiss Army knife example, and I really like that one. I'm gonna have to put that one in my tool belt as well. I'll use that example in the future.
Nuclear pharmacy elective heard it in. I was like, oh, I like that. I'm gonna take that too. That was 8 years ago.
That's a good one.
Yeah, so continuing the conversation, so Mike and Bobby, in your experiences working with patients on the ground floor of medical cannabis dispensaries, how do clinical trials and traditional research papers that pharmacists are accustomed to referencing help with your patient interactions? And what kind of tools do you guys personally use to help navigate the conversation?
Well, I guess when you're thinking about from an initial standpoint, when I first entered the space, I was very open with my team. I've been in medical cannabis since July of 2019. And when I joined our company, I literally told my team, hey guys, I only have a 4-hour certificate under my belt, but I know a lot of science, but I'm kind of new here. If you have any questions, let me know. I'll look it up. I had access to PubMed, which is a luxury. So I kind of leveraged that to my advantage in the space. But in a nutshell, like when you look at the broad picture of like, are these research papers being used in the space? It's yes and no, technically. Yes, as in, yes, there are people who have taken advantage of what's available in the industry to learn, do use it. But you see a lot of anecdotal evidence being used on a patient-to-patient basis, and we'll kind of dive into that probably a little bit later. But for me, I only really dove in. Well, one, I was kind of trying to figure it out on my own with my PubMed, like in my office, studying and popping out and chatting with people. But what kind of gave me an edge was entering cannabis pharmacist or cannabis healthcare professional organizations, like just the clinical curriculum. I've done every single module. I've also I'm in ISCPH and I'm on the board there. And I've taken all the training programs. So like you got to dive in, because at the end of the day, we don't have clinical guidelines here. So we need to kind of learn how to get what the best evidence is. And even if you don't have access to PubMed like I do, there are still resources you can use to kind of use it to like kind of build your clinical repertoire. And the last thing I really need to emphasize while I'm here, what's in your tool belt can also work here just fine. I like to keep my knowledge up to date on HIV, for example. And one of the things that I've made in terms of my best practices whenever a patient who's living with HIV comes into the dispensary, I haven't talked to them yet, I pull them aside privately to have a conversation, one, around determining if there's any drug interactions going on with their meds, because in the way Pennsylvania is set up, I can't see their meds. I don't know what's going on. A lot of these people are typically underserved. And then also, yes, smoking is not legal in our state as a form of consumption. Many people do it, and there's other complications with smoking and HIV. They're higher risk for cardiovascular issues. So I'm having these conversations, and in one of those conversations, I found out one patient stockpiled Delsum due to fears around COVID, and that patient was on Simtuza. You can't take Simtuza with Delsum or dextromethorphan because you will robotrip due to a severe drug interaction through CYP3A4. That doesn't even come up on the HIV drug interaction checker. So like the end point here is dive in head first and also blend your current knowledge.
Mm-hmm. And I think very similar to what you were saying as well, Mike, is the idea of taking what we already have in their tool belt and then being able to apply that to the medical cannabis industry or whatever portion of the industry that you're in. So to give an example, here in Virginia, we do uniquely enough, the patient has to fill out a patient intake form prior, where we do have to get the actual list of current medications, but that adds a new stressor to us here in this market. So now having this list of their medications, we're held with the responsibility of checking for drug-drug interactions. So one thing I can share with this team, a tool I've been using since pharmacy school, when you look at clinical pharmacology, when you look at Medscape, these different tools where you're able to look up the interaction between two different medications. Of course, you can't type in THC or CBD as they are normally, but we do have FDA approved forms of both THC and CBD that are on the market, whether it's synthetic or, of course, in its natural state. So the idea of plugging these drugs in with whatever medications this patient may be currently taking gives a great snapshot of what these person's interactions may possibly be, and then be able to use that to dive a little bit deeper into what the actual dosing intervals may be. Is this something where you can take these together? Is this something where we want to separate 4 to 6 hours? Pretty much using what you've already been doing in pharmacy. I would add, though, one unique additional layer that I love about patient interactions that we have here is that I feel like, especially for me, this is the idea of pharmacists practicing at the top of their license. For in Virginia, anytime a patient comes in and would like to pick up a product, they have to meet with a pharmacist for a consultation prior to that first dispensing. Now, granted, when they come back for additional visits, that consultation is now optional for them. But for their first time, they're building that bond. So the ability to build that bond, the ability to be able to recommend which products you think may work best for them, the ability to recommend what dosing regimen may work best for them, the idea of being able to dive in a little bit deeper and pick out cannabinoids. So speaking to the topic of actual research, I do have a patient I've been working with currently that was actually a veteran, retired from military, and was a double amputee. So trying to dive in very, very deep into what forms of inflammatory relief we could resolve, what types of actual pain modulation we could resolve. And it took me back to my actual days of pharmacy school. I wanted to do a little bit more research. I didn't want to rely on what I've done so far for other patients. So diving in to learn more about the strengths of CBD, getting more into the terpenes that also offer anti-inflammatory properties. These are things that we already been exposed to them in pharmacy school, diving into JAMA, diving into PubMed, diving into all these different research tools, but then using it in a different way and searching for cannabis. So there is more information out there than we think. So let's see. Moving into a preview of the course material, why do you think it's so important for us pharmacists to speak the same language when it comes to cannabis terminology?
When it comes down to communication in general, if we're not all on the same page, it's going to create misinformation and confusion amongst patients. I don't want to hear a patient, oh, I spoke with so-and-so and they said this, and then you're speaking to me and I'm saying something that's different about the same topic they're talking about. That ultimately creates distrust between healthcare professionals anyway, and a bit of confusion between the patients in an industry that doesn't necessarily want us here anyway. And a lot of the people who have been advocating for cannabis, a lot of patients who have been consuming this for years, especially if you're not on the same page as somebody else, you're going to be disregarded. Now, besides the miscommunication and the misinformation, if we're all on the same page across the board, it'll just do bounds of a difference for the patients. I mean, like the terminology sativa, indica, and hybrid, I just kind of avoid that altogether and try and focus on like teaching the patient about the terpenes and the cannabinoids, which then also leads to the question, right? What's full spectrum? What is even like? There are some things that we still don't even know though, and don't have clear definitions for throughout the industry, which on almost a paradoxical note, I think is a beautiful thing.
Mm-hmm.
Because like if we're questioning together and having a discussion, we can learn more from each other. Um, but ultimately, just going through that full spectrum vein, just taking that one little bit step further, when a patient comes to me and they tell me they have like this product they got from like a gas station, that it's happened way too many times for me to count.
Mm-hmm.
The CBD like they got from a gas station, and it's like dosed at like the bottle literally I remember said like 50,000 milligrams, and well, the highest dose of CBD ever given to an individual has been 6,000. So I know that one, that couldn't have been accurate. But two, they told me they were taking about 10 milligrams according to them, and it was effective for them, and they wanted to get 10 milligrams of a product at my dispensary. Well, all the products I have are going to have THC in it and be to some definition be full spectrum. So if by full spectrum, we're talking, we have cannabinoids and we have terpenes in there. And depending on the product too, we have the whole plant extracts, which is also thought to be really helpful. So that 10 milligrams of of a full spectrum CBD in theory is gonna be more potent than the 10 milligrams of the isolate, because you got all these other guys working together. Like you were just talking about your veteran who is a double leg amputee, and looking for selecting the various terpenes and cannabinoids to help benefit them the most. That's what can happen here too, but we might actually accidentally overdo it in some people depending on where we dose them.
Mm-hmm.
Yeah, totally agree, Mike. And one of the frustrations that I experienced when I entered this industry was because there was a lack of awareness, a lack of standardization of how we speak to customers. So a good example, and in real practice, a lot of the selections that we make for patients are product driven versus science or evidence driven right now. And having a product in front of you that you can't cohesively talk about without saying these terms is that's the starting point that we all need to collectively agree on. It's not necessarily a product focus or strain specific that we're recommending for patients. It's a type 1, type 2, type 3 of the cannabinoid ratio as well as terpene profiles. So being able to talk about that on the same page with healthcare professionals, it starts there. And then as we have to, I'm sure if you work in the medical cannabis dispensary, you're educating bud tenders or dispensary technicians to a certain degree. So that vernacular, the vocabulary that we're using really needs to pass on so that they can get the same experience every time they talk to, whether it's the pharmacist or the cashier that's ringing them out. Just have that baseline expectation of what the vocabulary should be.
Mm-hmm.
Yeah. And so moving on to a little bit about experience and tolerance, what we see and what we consistently talk about in cannabis, it's an individualized process to discover your therapeutic dose. Since there's so many variables to consider from both the pharmacokinetic end and the pharmacodynamic end, can you guys give instances in real practice where this issue was front and center of the conversation?
I had a patient who would consume a full syringe of what's called Rick Simpson oil. So Rick Simpson oil is like a full spectrum extract, typically made via ethanol extraction methods, and contains whole plant waxes. A full syringe in my program is between about 700 to about 900 milligrams of THC, typically, along with other cannabinoids and terpenes. This patient would go through it in about 2 days, but at the same point would rave about this product called Chiba Chews, which are not available in our state. And in that instance, I was kind of confused because the dosage she was taking of these taffy-like products, the Chiba Chews, was about 10 milligrams, and she would feel it. Whereas she's taking well over hundreds of milligrams in a day of this Rick Simpson oil and not feeling any effect. So at that point, I was kind of stuck. After I have like 35 pages worth of documentation on this patient, trying to help navigate various products. And one of the things I suggested she try was to use a traditional like tincture in quotations, because they're not real tinctures in our program, they're oil-based, but eat taffy with it. No evidence on that at all, but it worked, and it helped the absorption. But the other thing I also needed to think about here too is what is her baseline SAT? So in this case, she was assigned female at birth, and I use that terminology specifically because I see a lot of trans patients in my area of practice. So if you're premenopausal and you have high estrogen levels, you're gonna have less cannabinoid receptor expression, and thereby also have an increased likelihood for developing tolerance. I highly recommend watching the women's health modules. They're great for SCC. And that's kind of like the tricky bit here, because there's so many variables that come into play. And with her, I still don't really know why it worked.
Mm-hmm. And very similar to your story as well, Mike, I also have a patient experience that kind of highlights the importance of understanding the ADME of pharmacokinetics. So I had a patient who came back to us because one thing that we always like to recommend is if you're a new patient just now starting off on cannabis therapy or just starting cannabis therapy with us, to keep a journal where you can track down the notes, how this actual dose made you feel, what dose you took, if it's a proper time to increase that dose, the whole 9 yards. So there was a patient who came back in to see us that had some concerns. So I wanted to make sure I stepped in to offer my type of expertise. And the concerns that they brought were they have been consuming these products. They have been consuming cannabis for quite some time, but they were just now getting their hands on more concentrated products since getting their medical card. And these concentrated actual products led to them feeling much more sluggish the next day. They started to notice that they were consistently feeling under the influence of THC. So I went and did a little more research, pulled this actual patient's full notes, got them complete a full intake form for me, and noticed that this patient was living and operating with only roughly about 20% of their liver. So with cannabis being a product that is actively metabolized in your liver, and you now exposing yourself to more concentrated products, this person was definitely dealing with a situation where they had increased metabolites of the THC. So working with them to once again be able to space out their dosing instrument, because I'm a person who likes to advocate for, what's the right way to say this? I believe there's a way to introduce cannabis therapy to almost any patient. Depending on what type of barrier they may have, there's always going to be some form of a different route of administration, a different type of dosing instrument, whatever we can do to make sure that you can still receive some type of therapy. So I'm never the type to say no just because you're down to a small portion of your actual liver that will push back. Can you all still hear me? All right, perfect. So the idea where if you are dealing with this, let's look at, instead of consistently dosing yourself every 4 to 6 hours as you normally would have with a lower concentration product, let's look at going into more so once a day dosing and write notes on that. If once a day dosing is it, of course, relieving the style effects that we're trying to relieve, let's look at increasing that slowly but surely over time. But being able to look at each patient as an individual, I think it's something that's very, very important in this industry, because what works for Joe over here may not work for Emily, and what works for Emily may put Joe back to square one. So it's very much so an individualized form of therapy, but understanding your base terpenes and your burst cannabinoids helps to hopefully make this a little more easier for all of us out there. But PK and breaking down ADME for specific patients is definitely something I use on a daily basis in the practice.
Yeah, but when's the last time that you used that in retail pharmacy practice, Bobby?
That's why I said being in this part is definitely practicing at the top of your license as a pharmacist. I can't recall a time where somebody asks me, is this the proper dose? Should I tweak my dose? What time should I take this? I'm normally looking at information that another provider has already given and making sure that that is accurate and correct, and then translating that to the patient. But being held responsible for that information, not only is it fun, but it reaffirms what we're actually out here doing. So very much so enjoyable. Let's dive a little bit deeper. So when a patient has full autonomy over the products that they're purchasing, how much do they consume and how often do they consume their medicine? This is a clear delineation from when we're used to traditional retail pharmacies. So how do we pass on the responsibility of treating cannabis as a medicine for patients? When we look into this question, I think this is great, where I mentioned earlier, in Virginia, you're only required to have a consultation for your initial visit. But after that initial visit, this patient is now on their own for selecting whatever products they may want to consume or may want to help relieve whatever style pain or therapy they're looking for. So in you all's experience, how has that been?
When it comes down to it, because at this point, because their autonomy is now given to the patient, the script has been flipped.
Mhm.
And it's kind of like, how do I navigate that? It almost feels a little cumbersome. But it's also like, for me, it was a very interesting psychological journey because I now have to completely change my approach. So what I have learned helps more than even giving clear instructions on how to take the product is you have to fundamentally change how the patient looks at the product. And a lot of the times I would do this simply by just talking about intentional consumption and basic psych principles. So for me, I tell them, like, if you're consuming to numb, you're going to numb. If you're consuming to treat, you're going to treat. And that intention makes a big difference. And even that sometimes those words open up a broader discussion. And from there, I can then talk about the plant itself, what terpenes and cannabinoids may be helpful. How do we select for these things? And that excitement alone paired with that vulnerable conversation has actually brought patients to come see me for consults. So none of this actually happened to me in a formal consult most of the time. Typically, I'm at the point of sale. So in Pennsylvania, the patient doesn't have to have a consult with the pharmacist. So what I would do is I would set up shop on the floor and just like be reading, doing something, like listening while checking as the patients came through. So every single patient that came through, I had to review their cards to make sure there were no restrictions. So if it said no inhalation, guess what? You're not getting flower, you're not getting vapes. Just like that. But by sitting out near the registers and having a relationship with what we call patient consultants or bud tenders, depending on your state, you can almost like tag team a conversation and pull the patient in to get them buy-in. And then from there, you provide the education, you provide the instructions in a way that's not overwhelming, because ultimately at the end of the day, they need to be able to digest it. So do you give them a tracker? Do you give them a diary? Do you suggest a diary? But in order for you to get to that point, you need to fundamentally change their perspective on what they are currently consuming.
Yeah, and I'll share my experience was really frustrating when I started, because in New Jersey, our medical program, there were no limitations on what they can purchase beyond the quantity they can purchase. The patients had full autonomy into what products. So I would sit through a counseling session for maybe half an hour. And even at the high level overview of diving deep into their medical conditions, and what I think would be best for them to either initiate or continue therapy, they can go ahead and go back to the dispensary and purchase the product that contained the highest amount of THC. So imagine being a clinician where you're trying to give them the best benefit available, but they don't listen, and that happened, more than once. So. As an educator, I would say it's uncomfortable taking a back seat to a patient's therapy. And I choose to view it as I'm taking the passenger seat instead of the back seat. So we're here to guide them in the best direction possible. But at the end of the day, they need to take that intentional approach to what they're taking. If you're going to call it medicine, treat it as medicine, right? So these basic, outlines that we talk about on this slide, establishing minimum therapeutic dose, this all makes sense to us as clinicians. But to be able to relay that message to your target audience, that's a whole nother level of conversation that we need to have. So again, being an educator versus a clinician, being able to just understand the limitations of how far your practice and your advice will go in the patient's eyes, and mostly just accountability, passing on that accountability measure. Like this is something that you can use for recreational purposes, something that you can be very casual with, but it all takes that mindset and reframing of the mindset in order to really get to your therapeutic goals when it comes to what they're looking for specifically.
If I can hop in on this one as well, One unique experience that we're starting to see more and more here in Virginia, especially as we get closer and closer to more adult use coming online here, is the idea that more people hopping into the medical market are people who are truly just grabbing their card to be able to get access to products before they can do it on the other side. And one thing that I like to do, especially when we're having this initial consult that's required here in the state, is enforcing the idea that any patient as of right now, in my eyes, or anybody who's consuming cannabis, is consuming cannabis one way or another for some type of medical relief. Now, whether they're looking at it in that way or a different lens, anxiety reduction, relaxation, even mood elevation, these are all still forms of medical relief. So the idea of training them and almost over-educating them in that moment, so that whatever we do discuss in this first consultation will provide you with enough skills and enough of, I guess we can say, personal confidence to be able to drive you through the rest of your therapy. And one thing that I have learned from these conversations is that once you build a great bond that first time, even though it's not required, they do want to continue to come back. They do want to continue to get your expertise. They do want to continue to say, hey, I'm looking at this product over here now, Bobby. How do you feel about this product? What does this product do for me? Would this product be good for me? So the idea of showing them that somebody is there, like you said, Alan, to guide them through the process. We're once again going to be a passenger seat driver. I'm going to add that driver to the end. We're going to be a passenger seat driver instead of a backseat one, but being able to hold their hands, let them know, because majority of these people aren't used to even having to speak to somebody prior to making a cannabis purchase. So letting them know, hey, you are still empowered. This is still the same way you've been relieving yourself in the past, but now you have an expert on your side to be able to let you know what's right and what's wrong. So building that relationship, as I've seen in this market, has been something that's been very, very beneficial. But let's see, right over back to you, Alan.
Yeah, and to on that note, the traditional prescriber regimen that we're used to, where a physician will diagnose and prescribe, and the pharmacist is really, I don't want to say the middleman, because our role is really important in furthering patients' health outcomes, but at the same time, we're not in the driver's seat in that part of the conversation. Whereas in the medical cannabis programs, you need to see a physician to enroll in the program, but they're not actively prescribing and recommending products. In fact, most of the programs that I've dealt with enrolling patients into the medical cannabis program here in New Jersey were very, loose as far as patient care comes. Like it's a 10 to 15 minute conversation, a telehealth or telemedicine conversation with a physician. And they're like, okay, what are you using this for? Have you used it in the past? And it was very, very, I wouldn't even say high level. It was just like, okay, well, I'm just going to pay you $200 and you get into the program. And it's really unfortunate because that disconnect is very prominent when it's an actual patient looking for medical care. It's one thing to get access to products, but it's another to get the beneficial health care that physicians and pharmacists can provide. So, what are some instances that you guys have experienced that there was a noticeable gap between the information a patient's physician tried to give the patient versus what actually played out in practice?
There's a lot of examples, but there was one that I was alluding to earlier with my absorption issue. This patient, so as someone who works in Philadelphia, Pennsylvania, what I made it a point to do, especially considering how the market is run and what my role is primarily kind of funneled into checking patient certificates for making sure that everything's okay. I made it a point to really educate my team. So I educated my team on cannabinoid hyperemesis syndrome. I educated them on, when asking about drug interactions, I educated them on how to calculate tincture concentrations. And again, I say tinctures in quotations because most of them are not true tinctures, as they are medium chain triglyceride oil based. So I had a really nice safety net to catch patients and bring them to me. And in this particular case, the patient, who was also a healthcare professional, which made life a lot easier actually, told my patient consultant that her doctor was saying she was having CHS. I immediately was pulled in and I had a conversation with the patient. The patient did not have CHS. If anything, cannabis relieved her vomiting. She had a very complex history, and thankfully she was involved in speaking with many other members of our healthcare team. And I personally thought, because I personally thought it had to do with secondary adrenal insufficiency from her opioid use. So she was taking chronically high levels of opioids due to endometriosis pain. And ultimately, what I was then going to suggest is talk to the pain management doctor so we can titrate her down. Long story short, the endocrinologist agreed with me. And then they started tracking her levels. And then she told her pain management that she wanted to titrate down. Her pain management doctor stopped her pain meds that day, and I was treating withdrawal in a matter of hours. So that, and it ultimately it worked out well. Like, she's been off of opioids for, at this point, at least 5 months. Her mental health substantially improved, but it all kind of started with me being pulled in to screen for CHS when in fact it wasn't CHS.
Mm-hmm. Mm-hmm. And if I can add to your story as well and kind of add some experiences, one thing that I think is very important in any form of healthcare is the importance of that triad of healthcare. So the relationship between the pharmacist, of course, whoever is the prescribing physician, and then the patient is going to be the relationship that pretty much drives their care. So when I look at the market here in Virginia, we have a very, very unique relationship set up where physicians or practitioners are actually certifying the patient. And then once that patient is certified, they come on site and deal with pharmacists to be able to help guide their therapies. So this is something that initially, you always start out with a little bit of friction. You have to work through those relationships. But now I would say that it's working very, very well. It's the idea that once that physician or that actual certifier fills out everything on their end, they now feel much more comfortable sending their patient over to a place where they know they're dealing with another trusted healthcare professional. Another thing that I can add to that part of the conversation as well is the idea that we're not just checking and dispensing how we were in retail, just to reiterate some other forms we've spoken about earlier, but we're actually sitting down having conversations. We're actually doing drug-drug interactions. We're actually helping to select which actual product and what style dosing regimen they should use. Granted, even if it's for their initial visit, that level of education, once again, adds comfort to the certifier to let them know that triad is still operating on this side of the healthcare industry as it did on other forms. So I think that's something that's very, very positive when you look at that light. Some other things I think are a bonus, at least in my specific market that I'm working in right now, is that anytime we're dealing with a patient under the age of 18, and we would like to dispense any form of a botanical product that has higher levels of THC, we have to build that relationship once again with their certifier. So we have to reach out, we have to have conversations, we have to once again decide together, is this actually the best recommendation for this patient? So it brings back once again the idea of pushing that triad of healthcare back to the forefront of this conversation and allowing cannabis as a medicine to be treated in this way, at least kind of similar to how other Western forms of medication are treated. But something that I would add to the conversation is the idea that similar to how we were in pharmacy, there's a lot of education on the certifier and practitioner side as well. So working to educate the healthcare groups in general, whether that's a pharmacy group, whether that's a group of nurses, whether that's a group of practitioners, whoever the group may be, I would say that there is a lack of education across the healthcare industry in general. But that's why mediums like SEC and the modules and different training programs out there will hopefully slowly but surely change that narrative. But just as much as I've seen active pharmacists interested in getting involved in the industry, I've been seeing a lot more physicians and certifiers actually interested in getting involved in the industry as well. So hopefully after we work over this education hump, we'll get to a space where we're able to all work together peacefully.
Yeah, and I just want to add on to that, like, this is my personal opinion, but a lot of the pay-for-play doctors that are out there that simply charge a person a fixed amount, they're not doing a service to the medical cannabis industry. Like, yes, it's one thing providing access in states that are medical only, like Pennsylvania and Virginia. Adult use sales haven't started in Virginia, right, Bobby?
Mm-hmm. It has not yet.
Right, exactly. So it's one thing to provide access, but now that New Jersey has transitioned to adult use and anyone that's over the age of 21 can purchase it, these conversations have to happen more with people that are knowledgeable about medical conditions, because now there's not even that layer that you need to go talk to a physician for 15 to 30 minutes about your goals and outcomes. They can literally just walk into a dispensary and purchase it. So how they choose to use it is up to them. But that was just the point I want to get out there. There's a lot of physicians that I've met that are extremely knowledgeable and there for the right purposes. But the majority of patients enrolling in medical programs right now are just participating in a system where it's pay for access. And that's not what true healthcare is. So that's my a stool that I want to stand on.
Well, I know you got to hop on that high horse, man. Got to let them know. But no, down a little bit deeper. I know we've had some conversations about almost a lack of training that we receive in this topic while we're all in school. So while in school, we talk and learn a lot about bedside manners, but it takes an entirely different skill set to really connect with your patient on a personal level during these actual conversations. So how do you all think empathy, or why do you all think empathy is such an important part of the conversation in the cannabis industry?
Well, first, I think we need to know what we can give. So, what is empathy versus what is sympathy? Because I'm not going to be able to really empathize with every person that comes through my doors. So, empathy is truly understanding that person's experience, whereas sympathy is pity or feeling bad for somebody. And that's just chump change, in my opinion. I want to give you the empathy. And that kind of sets the tone for our conversation here, because as someone who sees patients who've told me about their rape experiences, being shot, etc., on a regular basis, I can't empathize with that, right? So we need to take that as our base. The next thing we need to think about is what types of people are coming into the dispensary looking for treatment. Well, many of them have been stigmatized by healthcare professionals in general, right? So they're not really going to want to talk to us. I've had that a lot. Thankfully, again, I had such a great rapport with my team, where they would pull me into conversations with so many people who did not want to talk to me, and the patient would I would walk away, and they'd be like, "Thank you for bringing him in." And then on top of that, a lot of the times with these patients, it's their last resort, and being able to kind of handle these more sensitive conversations is key. So how do we utilize empathy? Well, one, and two, what do we do if we can't? And I think the most important bit here is, what do we do if we can't? What if we really can't empathize? Because I don't want to give sympathy. Well, the first, set boundaries. And by setting boundaries, not you give the patient the power to set those boundaries. Like if I'm having a conversation about PTSD with a patient who has serious trauma, I want to give them the power and remind them that multiple points. You can talk about what you want to talk about. Are there any things in this conversation that are off limits? I want to make sure that you are validated here. This is a good space for you. So you need to help create those conversations. And that doesn't necessarily just apply to PTSD. It applies to transgender patients. It applies to Vietnam vets. It applies to every person that comes through those doors. And a big thing, and this is highlighting a broader issue we have here, is there's this big emphasis in general with our society on comprehension over compassion. Right? So I need to understand you for you to get my compassion. And that's a big theme. And that often trickles over into healthcare. So what you want to do is just listen to the person who's in front of you with compassion. And then after you do all of those things and set those really important, powerful, almost boundaries in place to allow the patient to make the experience what they want, you're going to get more buy-in. And by listening with that compassion and you make the product recommendations, they're more likely to listen to you than not. They might not take your entire recommendation, right? But they might try something out and then come back and have a further conversation. You set that tone for them to then come back and create that safe space for them to do whatever, to be as open and vulnerable with you as possible. So for me, it's not necessarily just about empathy, because I can't empathize with everybody that comes through my doors. But how do I make the experience the most pleasant as possible? Because at the end of the day, this is trial and error. What I recommend may or may not work, but at the very least, I want to make that person's life a little bit better in any way, shape, or form. And if it's through that conversation, hey, I did a good job. That's kind of how I look at it.
Yeah, absolutely. One of the kind of most interesting parts about going to work every day was that you never knew who was going to come through your doors. So a good example, in the same month, we had one of our oldest patients. It was a 96-year-old terminal cancer patient come in, undergoing chemotherapy and extreme nausea. And then a couple weeks later, our youngest patient that I've ever seen, an 18-month-old with epileptic seizures. So being able to empathize with those two patients would be a very hard conversation for anybody. But we have to put our best foot forward because we really don't know what these patients are experiencing before they come in our doors. It's not like we have that rapport with them where we can talk about things very seriously. Sometimes we don't have the time, capacity, bandwidth when we're trying to force as many people into our facilities and out the door because of metrics, right? The same thing goes in corporate environments. But at the same time, we want to make sure we put our best foot forward. And this was kind of anecdotal about one of our patients that came in. It was an elderly Black male. And this ties into the social justice issue of cannabis, where he was like, Doc. And I don't correct people when they call me doc because I am technically a doctor, even though I don't prefer to be called doctor. I don't know about you guys, but that's just my thing. He said, Doc, how can this product that's sitting in front of us, like I've had family members locked away because of it. How can I call this medicine when, it's something that caused such turmoil for my family? And I didn't really have a good response for him. I nodded my head. I understood. And that's what really led me to look at the war on drugs in a different view, a different lens, because some people are still dealing with that part of the stigma. So how do you have a conversation about taking an intentional approach to this as medicine when they're suffering on the back end? That's just one of the situations that I've always played back in my head when I go into conversations, because we really don't know what this means to the person in front of them. So whether they're on their last limb, or whether they're using it casually for insomnia or something that's not necessarily life debilitating, we just want to make sure that we take care of them. As providers of healthcare, this is our prerogative. This is the pharmacist oath that we took in school. And to this day, I want to carry that message onward and to all the patients that I see.
And to kind of add to what you two are speaking of as well, I really enjoy the idea where pharmacy and pharmacist is one of the most trusted positions within the healthcare industry, one of the most trusted physicians and one of the most trusted roles in general. So the idea of having a pharmacist in this space, once again, is just adding to the conversation, because kind of similar to what you were saying, Mike, these are people who have been told no, have been pushed away from certain therapies over and over and over again. Most people who turn to cannabis are people who have received not the best news, or normally cannabis is their last step. So the idea of making sure that these patients are being met with someone who is understanding of while they're coming in, and like you said, you may not be able to relate to every single patient, but making sure that we're applying the skills that we already have as one of the most trusted professionals, and being able to apply that to somebody who may be at their wits' end when they think of their care. But one thing that I can say that can add the cherry on top is that there haven't been many patients who have come in the grumpy mood, and the next time I saw them, they were still in that mood. The ability to not only change people's health situations, but to also change their mental has been something that I really pride myself on here. So even though they may come in, they may have a fight for you, may have to get an earful in that first time, that conversation and your intervention at that point, I promise you, will help fuel you all's conversation for the rest. So definitely some great things so far.
And most of the pharmacists' work have come from traditional retail backgrounds, so we're familiar with what an unhappy customer looks like.
100%. 100%.
So I don't know if the chat is disabled, or I can't see if there's any questions. But at the same time, you can always reach out to the SEC directly, and they can divert the questions to us if you have anything specifically. But as we begin wrapping up this session, what are some closing remarks or takeaways that you guys would like to give to the audience?
For me, I think this conversation's been like alluding to this with being around autonomy and the differences between our interactions with patients in this space versus traditional pharmacy. But we can educate all we want, right? But it may not necessarily do what we intend to. And that change in the role with autonomy can feel cumbersome. So what you really need to do, and this is even for myself, but first, leave your biases at the door. You're going to come across a lot of interactions where you might feel uncomfortable, that may challenge your views, or someone you may not align with. And in the cannabis space, you see everybody. So first and foremost, leave your biases at the door. The patients might bring their biases in, but that has no reflection on you. but leave those at the door. Second, and I can't emphasize this enough, learn your history, because you need to understand historical context to really see where a person comes from, right? So I never learned about the Tuskegee syphilis experiment. Why is that? That has broad implications as to how healthcare professionals are viewed today. I have not learned at all about the AIDS crisis and how thousands of people were let to die. How about how the vets were treated after Vietnam? All of these not only have political implications in conversations we have today, but also directly impact how people view us as healthcare professionals, especially in this space. And by doing all of this and then listening to the person in front of you while taking that context into consideration, that really is what translates to compassion. And that's really kind of how you make a long-term impact on a person. Yeah, you may not necessarily get the buy-in right away, but if you slowly work your way by understanding the different perspectives that are out there, you can make that difference. And remember, your perspective barely represents what the world looks like. So keeping that in mind by dropping those biases at the door before you even walk in is really, really important. And you'll learn something new from every person you speak to each day. It's pretty incredible and humbling at the same time.
Mm-hmm. And to almost add to what you're saying as well, one thing that I would love to reiterate, and we'll be definitely reiterating as we go more through Canna Talk series, is the idea of how impactful pharmacists are in this industry. From hopefully what you'll be able to see through this conversation, having patients actually come on site and have somebody similar to Mike, myself, Alan, anybody of our same attributes to not only speak to, but to help guide them through the process, from my experience, has been life-changing for a lot of these patients. They're not just coming in and picking up the thing with the highest THC concentration anymore. They're not just coming up and picking up the thing with the coolest name anymore. They're not actually starting to shift their mindset and their thinking to which actual product will give me the best form of relief. And I think that is the overall goal of medical cannabis as of right now, but we haven't been actively able to achieve that. So I think pharmacists physically in dispensaries or physically within this industry is something that will help to hopefully slowly push it in that way. Another thing that I can add as well is the idea that pharmacists included in this process is still a very, very new idea. This is definitely still an idea that is very limited. As of right now, there's roughly about 5 or 6 states that have us included in their process. So when you think about that, and then when you take a further step into the idea where if this is the impact that we're able to make in these markets, what are patients in need of in the markets without pharmacists? What does that patient experience look like for patients without access to a pharmacist in the cannabis industry? So granted, they may have their certifier, granted, they may have somebody to walk them through while they're physically on site, but they don't have somebody who is actually specialized in drug therapy to be able to talk to them about these, of course, facts. So I'm very, very interested in continuing to advocate for the role of pharmacists within this industry, continue to advocate for the importance of pharmacists in this industry, and once again, advocating for the importance of shifting everybody's mindset from the idea of, hey, I'm consuming cannabis, I just want to go receive the relief of THC, to the idea of, hey, if I'm going for anxiety reduction, if I'm going for relaxation, if I'm going for more of a mood elevation, let me target that to make sure I'm maximizing my actual consumption. So whether that's in adult use, whether that's in medical, we can always find a way to offer a lending hand as a pharmacist. So hopefully that's something all of you all as listeners were able to pick up from today's conversation. Anything from you, Alan?
Yeah, I mean, participating in the legalized industry has been incredible, and seeing the active change happen over the course of the years. Like this year, Maryland and Missouri have legalized cannabis, and that just means more walls are breaking down. And the fortunate part about pharmacists is that we understand what regulated industry should look like, because we come from the pharma world. You know, what are USP standards? When you try to open a compounding pharmacy, we have to follow certain protocols, and the same thing should apply for manufacturing cannabis products. If we want that same kind of safety profile, if we want to have the same expectation for labeling requirements, these are all things that we are familiar with, but at the same time, when you enter the space and realize these boundaries are not there, you're like, what's going on? Like, how can this be? And that's what we're literally dealing with on a day-to-day basis. So from a pharmacist perspective, there's a lot of room and opportunity for other pharmacists to get involved. And the advocacy side is always there in the form of, this industry is not well established yet. Like state by state piecemeal regulation, which we're going to go through in the cannabis policy module, that allows a very fragmented way of practicing. And to be able to advocate and see the changes that we want that would help our patients have better health outcomes, we can't do that necessarily in a traditional healthcare role. Like hospitals, pharmacies, big pharma, as they call the pharmaceutical companies, these are all established practices, all the way up to the PBMs, the third-party reimbursements that we deal with on a day-to-day basis. There's not much that we can say or do to change these practices that are existing. But that's not the case for cannabis. I truly believe that in the next 5-10 years, a lot of reform will happen that will allow third-party reimbursement for medical cannabis. And that's going to be a game changer for a lot of people. Just being able to keep on top of what's happening around the cannabis industry and how that tailors into day-to-day experiences. It doesn't have to be this dramatic, life-changing scenario where a medical patient discovers cannabis and can walk again from not being able to walk, right? It's not necessarily those little changes that we are hoping to shoot for, although those stories and success stories are amazing when you do hear about them. Just being able to integrate cannabis into daily lifestyles as a day-to-day outcome, and being able to provide those small wins. I think that's what every healthcare professional should really be shooting for as the low-hanging fruit in this case. But yeah, that's my note to end on, and I'll let you take us home, Christine.
I think there's just one question in the chat. I know we're getting to the very end of the top of the hour, but I just want to see if we have 1 minute to address this. Someone asked, can dispensaries refer or have in-house cannabis clinicians or access with first purchase in your states?
So I can speak here to Virginia. Here to Virginia, if you're registered as a certifier, you cannot physically have any relations with an actual facility. So if you are not registered as a certifier, of course, you can come on site, you can educate, but you would not be able to officially certify somebody. Now, on the flip side, if you are a certifier, you can send as many people as you want in and everywhere, but you can't physically step foot just to make sure they have separations there and they're not, of course, creating any type of monopolies. But there are ways for practitioners to have an influence.
I mean, in Pennsylvania, a lot, if that's ever going to happen, it's typically at a separate event outside of the dispensary, and it requires approval by the Department of Health. People like to think that the pharmacists in dispensaries can do the certification. That's never the case. It's just one or the other. But if there are any events that I've been to those events where there are providers doing certifications for patients at site, it's separated out. It's never within the dispensary, especially since you have to have a card in order to be in the building.
Mike, one thing to add too, I know my apologies for cutting you off, we're just getting short on time, is that one thing we're proposing here in Virginia on this next round of regulations is the idea to have pharmacists stepping forward as actual certifiers if you're working in the space. Because just imagine if somebody wanted to come and pick up a product, but they drove 2 hours, didn't have a car the whole 9 yards, somebody on site could hopefully be able to open that door. But I'll keep you updated how that goes in this area.
I like that, because especially just one of my biggest gripes is that I would do certs and I would see check for drug interactions with primary care meds, and I'm like, they were right in front of you. But they were right in front of you. It takes come on, minimal effort here. But at least if you guys are doing it, it's gonna happen.
Yeah, we're pushing for it. I'll keep you updated on what's in progress. Probably early next year.
That's awesome.
Wonderful. Well, thank you. Thank you all so much. This was such an enriching conversation, and thank you everyone for joining. I see there's 1 or 2 other questions we didn't get to, but join us next time. We have 2 more sessions of these Canna Talk episodes. So December 7th, we'll be hosting Dr. Cody Peterson. He'll be addressing his 2 modules about the history of cannabis medicine and also the future, where the field is going. So that'll definitely be really interesting. And then January 11th, we'll have Dr. Farzana Kennedy, who will really go into all the policy that is not straightforward in this realm at all. So that'll definitely be full of a lot of great impactful information. So thank you all so much for attending. We're so excited that we can host these for free and open to the public. So if you have anyone interested, any colleagues or any patients who are interested in learning more, refer them to these next 2 episodes that we have. Anyone can pop on and learn for free. So we're so excited to be here with you all. Thank you all so much for this great presentation. And check out cannabisclinicians.org if you want to learn more, if you want to join as a member, get any courses. We have a bunch of other free resources too, like a research library with over 800 articles that are vetted by board members. So dig around on the website and see what you find. And we'll see you next month. Take care, everyone.
Thank you.
Bye, everybody.